And in this session, we are going to discuss about vascular abscesses. So we are going to discuss vascular abscess in these broad headlines. What are the various arterial abscesses? Uh, how to make a good, safe abscess, and if there is any complication, how to deal with the abscess site complication, and uh, how to manage that complication. Then we'll also discuss about ultrasound guided vascular access, and as well as we are here in a field where the percutaneous intervention is really expanding, and now a lot of new things are being done percutaneously, which earlier used to be done only by an open surgery. So, like I'm referring to TAVI and EVARs. For that, the role of specific vascular closure devices have come. And it's also useful for early mobilization of patients, these specific vascular closure devices. So, what is the importance of a vascular access in a percutaneous intervention? Well, it is not wrong to say that what starts well ends well. I have seen a lot of procedures being doomed to start with because of a faulty access. So it's very important and very vital, in fact, very key that one should have a good understanding of the local anatomy and to begin. So what's the different vascular access sites that are routinely used for percutaneous intervention in we are referring for coronary interventions are the femoral artery, which is historically being the most commonly used and widely practiced access site, but because of its own limitations, the high risk of complications because of a faulty femoral access, people started looking for different safer options, and the best option came out the radial artery. So radial artery interventions are now the most preferred and recommended route for coronary interventions. And obviously, of late, because of the high incidence of radial artery loss because of transradial procedures, people have now started slowly and steadily exploring other options like distal radial artery. We'll discuss that also. And of late, there are some data that even the ulnar artery can be safely used for coronary intervention. And for some cases, even brachial artery, if you don't have any other options, you can also use a brachial artery. So we are going to discuss all of them, primarily the femoral artery and the radial artery accesses, which are the most practiced access sites, but we'll also touch upon the other access sites. So, as I said, that understanding of the local anatomy is very important for a safe puncture. So, if you see the local femoral artery anatomy here, that so the femoral artery is very intricately related to the femoral head, and its relationship, as you know, that usually it is actually oriented in this way that the nerve is the most lateral part, the artery is in the middle, and the vein is on the most medial part. And if you see the relationship further, I'll just show you by a diagram. So if I show you by this diagram that what is the relationship in the at the femoral head, the relationship of artery, vein, and nerve. So the artery is actually very much related to the inner border of the neck of the femur, and it lies along it, and the common femoral artery, it lies almost in the center of the head of the femur, and the vein is aligned to the inner border of the uh, uh, femoral head, and the nerve is most laterally. If you see further that we know by the anatomy background that the common femoral artery is actually a continuation of the external iliac artery. So beyond the inguinal ligament, this is the inguinal ligament, the external iliac artery continues as the common femoral artery, which further divides down into superficial femoral artery and the profunda femoris artery. And this bifurcation usually happens at the most inferior border of the neck of the. So this bifurcation happens at the level of the inferior border of the head of the femur. And the vein, if you see here, that the vein it lies along the inner border of the femoral head. So this is the vein here, and it continues superiorly and then goes below the external iliac artery, and then it communicates from the vein from the left side or the other side and forms the IVC. So this is our IVC, and this is the aorta. And the external iliac artery, you know, it joins with the internal iliac artery, and it forms the common iliac artery. So this is the general anatomy of the arterial and venous relationship at the level of the head of the femur. And if you see further, this is a angiogram, local angiogram of the femoral artery at the level of the head of the femur. And you can very well see here, if I pause it here, the various branches here. So if I zoom it further for you. So as I said that, usually if you see the direction of the orientation of the femoral artery at the level of the femoral head is along the inner border of the neck of the femur, and it lies, the common femoral artery, it lies at the center of, if you divide the femoral head into three parts, so if you divide it, the femoral head into three parts, so the common femoral artery, the orientation is almost in the central part of the head of the femur. Since this is an RAO view, so you are looking the artery to be anteriorly placed. But if it is an AP view, the artery is almost in the center of the head of the femur. And if you see the branches, so as you know, the external iliac artery, the most before it continues as the common femoral artery, it gives the, this is the inferior epigastric artery, and this is the deep circumflex iliac artery. And the inguinal ligament marks the border between the pelvis and the groin, and the inguinal ligament it stands like so. So the inguinal ligament lies here, and it extends from the anterior superior iliac spine to the pubic tubercle. And beyond the inguinal ligament, the external iliac artery continues as the common femoral artery. And this branch, the inferior epigastric artery, is very important because it can be inadvertently damaged and can lead to retroperitoneal bleed. I'll discuss later. So if you see here that the common femoral artery divides into the superficial femoral artery and the this is the profunda femoris artery, just at the inferior border of the neck of the head of the femur. And the functional part of the femoral artery is this segment. The common femoral artery segment is the functional part, because any puncture above the head of the femur or below the bifurcation of into SFA and profunda femoris can result into problems. Just to sum it up, the external iliac artery continues as common femoral artery beyond the inguinal ligament. Before that, it gives branches, the most distal being the inferior pedestrian artery and the deep circumflex iliac artery. The common femoral artery continues and it divides in almost 70% of the people just at the level of the inferior border of the head of the femur into superficial femoral artery and the profunda femoris artery. And the vein lies medial to the artery, and it is in the anteroposterior view, it is related to the inner border of the head of the femur. And the artery itself lies along the inner border of the neck of the femur, and it lies in the central part of the femur head. And the nerve lies lateral to the artery. So that is our relation of nerve, artery, vein, and this is the anatomy that we are concerned with. So after this discussion about the anatomy, we should go towards what's the technique of puncture. The technique that routinely practiced is, we call it a Seldinger technique. And so what is this Seldinger technique? I'll just briefly tell you about that. For that, what you do is that you take a needle and you try to puncture the anterior wall of the vessel. And when you have punctured the anterior wall of the artery, there will be flush of blood that indicates that you are in the lumen of the artery. Then you pass in a guide wire, and this it establishes your access into the lumen of the artery or a vein. Then you remove the needle with the guide wire inside the lumen of the vessel, and then you put in a sheath which has a dilator, sheath with a dilator. So what you do is that you insert that sheath with a dilator, and when you are inside the vessel, you pull out the guide wire and the dilator, and you have an access. And this technique, we call it the Seldinger technique. So coming to how do you proceed with the actual femoral artery puncture. So for that, it's very important to understand that there is a depth between the skin and the actual femoral artery. And you go at an angle when you are puncturing. So what I mean is that so if so this is our surface of the skin. Let me highlight it further. So this is our surface of the skin. So and our target is that that we should puncture the artery over the femoral head. And the reason is that if you are puncturing below, that is below, that means that you are puncturing below the head of the femur, or puncturing above, there could be problems. So the first problem is that when we are doing a percutaneous intervention, a puncture, when we have removed the sheath and we have to maintain a hemostasis, we apply manual pressure over the arterial puncture site. And when we are doing that, it is important that we have a counter pressure so that we can have an adequate pressure over the puncture site and it seals. So if you are puncturing very low, there could be two problems. First, that the puncture will be not over the head, so there will be puncture will be over the muscle and the tissues there. So when you are pressing over the puncture site for sealing it, you will not be having a adequate counter pressure. So there will be chances of oozing from that side. Second problem is that, as I said, that common femoral artery usually bifurcates below the head of the femur. So sometimes it can be high also, but the problem is that when you're puncturing low, there could be that you could be puncturing in and out between the SFA and the CFA. So there could be multiple rents there, and it leads to pseudoaneurysm formation because you may not see all of them just by compressing. But the bigger problem happens when you're puncturing very high. Suppose if you puncture very high, like for example here, that is above the head of the femur, what could be the problem? The problem is that usually, as anatomically, the external iliac artery, when it continues as a common femoral artery, it ascends over the femoral head. So if you see from distally to proximally, if you come, and if I trace the route of common femoral artery, what you can see in this drawing that the common femoral artery kind of dips into the pelvis. And pelvis is a potential space. We can say a space which has no bony part. There are just tissues inside, and you have structures inside, bladder and etc. So when you are puncturing very high, and if you want to seal this rent here, and if you apply a pressure on the surface, there is nothing on the back. It's just a hollowness there. So you are not going to have any counter pressure to seal that puncture site. Additionally, you have seen that there are branches like the inferior epitarsal artery. So you can just puncture one of those arteries, you can damage it, you can do away the procedures, but that damaged artery will continue to bleed, and it can lead to serious complication, which any interventionist, if you ask, is always wary and is prays that it never happens, that is retroperitoneal bleed, and that's a very serious complication. So how to manage this problem and how to make sure that you puncture at the ideal spot over the artery? For that, what we do is that the teaching that we have been taught is that either you palpate the inguinal ligament or you use the any hemostat, any opaque marker to mark the skin site which corresponds to the inferior border of the head of femur. So if I draw here for you the importance of the inguinal ligament here. So as I said that the inguinal ligament extends from the anterior superior iliac spine to the prevertebral buttock. So your inguinal ligament will be lying like that. So the most routinely practiced technique for any experienced interventional cardiologist is that what they do is that they feel for the inguinal ligament, and they use their fingers and they if you can feel the inguinal ligament, usually 2 fingers below will be the spot where the inferior border of the head of femur will lie. So if you place your finger like this over the touching the inguinal ligament, and you puncture 2 fingers below here like this, I mean like this. So if you are puncturing like this, this level will be at almost corresponding to the inferior border of the head of femur. But it is not always true, because you know that in some people the inguinal ligament can be lax, so it can lie very low. So if you use that as a marker, you are likely to puncture very low. Sometimes, particularly in thin people, it can can be very taut, and it may be very high, and you may be puncturing very high. In obese people, it may be very difficult to feel the inguinal ligament. So there are limitations using this technique. So if you ask me that what is the second best technique, is to use this hemostat or any opaque object that you have, maybe a scalpel, backside of the scalpel, and you check on the fluoroscopy that what is the position of the head of inferior border of the head of femur. So this is how we do here. You can see that in the back side of the scalpel has been placed here, and over the skin, and the corresponding site is noted on the fluoroscopy. So when we are using this, so our stent puncture will be at the site where the inferior border of the head is as related to the by the fluoroscopy. So what we do is that you mark by the inguinal ligament, feeling the inguinal ligament, or use the hemostat for marking the inferior border, and this marks our stent puncture. So this is our stent puncture, and you go at an angle of about 30 to 45 degrees. So if you see, if I extend this arrow, so this is where you will puncture the artery. And in normal practice, this can be a really useful technique, that if you use the fluoroscopy for a guidance of a stent puncture, and if you go at an angle of 30 to 45 degrees, you are likely to hit the artery with the needle just at the center of the head of the femur, away from the bifurcation, and not very high. But there are limitations with this technique also. So imagine if the patient happens to be an obese subject. So obviously the stent thickness will be more in that patient. So obviously your stent may be somewhere here. So this is my level of, and the depth of the artery increases. So if you use the same technique and you use the scalpel to measure the depth level of the inferior border of the head of the femur, and then you proceed at the same angle, imagine where you are puncturing. You are puncturing very deep. There are chances that you can perforate the inferior epigastric artery, and even if you don't perforate anything and you have a clean anterior puncture, there are chances that when you remove the sheath, you may not be able to secure a good hemostasis, and the patient will bleed later. So what to do? How to reliably puncture in an obese subject? One option could be that maybe you go at a very high angle, obtuse angle, that is, you go at maybe an angle of 60-70 degree instead of the 30-45 degree. In that situation, that looks like a good option. You can puncture it right there at the center of the head of femur. But the problem here happens is that usually when you do a puncture at a very vertical angle, the sheath that you will insert can get kinked, and there may be oozing around the puncture site, and obviously it will lead to hematoma. And additionally, it can create problem with tracking of devices through that sheath. So this is the trouble. So what I suggest is that in obese persons, what you can do is that maybe you take the stent puncture a finger below the level of the inferior border of the head of femur. So if instead of at this point, if you take a puncture here and you go at a same angle, there is a good chance that you will hit the right spot. So this is how a modification is needed in obese persons. What about thin subjects? Well, obviously in thin subjects you will have the artery very superficial, and it may be like this. So in that situation, if you use that marker, uh, the inferior border, it could be that you may be puncturing very low and just at the inferior border of the head of the femur. So in that situation, I suggest that maybe you go at a more narrow angle, almost like horizontally, and then you can hit there. Or maybe you can go just at the inferior, just above the inferior border of the head of the femur. In that situation, you can be there at the femoral head. So this was what you can practice and for a safe puncture. So after we have, by now we know where we have to puncture over the skin. So let's see by an example here, and you can see that a case being done where we are going to have a femoral access. You feel the artery with the three fingers or two fingers, whatever you prefer. The most proximal finger to the needle will be the skin puncher side, and rest of the fingers will guide you the direction of your needle. And it's very important this you note here that I'm going very slowly, gradually, and when there is flushing of blood, if I just repeat it again. So if you see here that the puncture being done, so you use the fingers for your guidance, and the other fingers help you to give you a direction, that in what direction you're going to proceed with your puncture. And the puncture with the needle, it is at an 30-45 degree angles, and it should be very gentle and slow, and you should try to have a tactile feel. And when you see this spurting of blood, that means that you are in the true lumen of the artery, and you then put in the guide wire, you remove the needle, and now we are taking a sheath with a dilator, and this completes our femoral access. And you should thoroughly flush it with heparinized saline. And one thing what one can do is that if you are doing something procedures where you require a larger sheath, it's always good idea that you take an angiogram of the femoral puncture site to see whether there is any local disease, is there any stenosis, so that you don't have any complications later. So this completes our femoral access here, that how to actually take an access. So what are the cautions that you have to practice? First is that do not force anything. I mean, this is a very delicate area, you can say, by way of incidence of complications. You can have a lot of complications if you are not careful. So do not force. Whenever you see that you are having difficulty putting in the sheath or maybe the wire, just review. Some possibilities I'll just give you by example. One possibility could be that the wire is not going in and it has proceeded to some distance, but it has not proceeded further. What could be the possibility? One possibility could be that maybe you have gone into an intima. Another is that maybe you have gone into a branch. So if your wire is going freely, it's fine. But if it is not, check on fluoroscopy. That what's the problem? Where is the wire not proceeding? So if there is any issue, your wire is curling, you have to just take out the wire and press that area for a few minutes. Another problem that happens, that you have got a good puncture, good flow, you put in a wire inside, and now what is happening is that your sheath is not going inside. So it could be the local tissue around, or maybe you have punctured very high. Maybe the sheath is being constricted by the fibrous tissue of the inguinal ligament. And another possibility could be that you may be very low and your wire may have come down into the SFA or maybe even the profunda femoris artery. I have seen cases like that but the person is trying to push in a sheath, it's not growing, and when you see on fluoroscopy, what you find that instead of the wire going into the external iliac artery, it has come down into the profunda femoris or maybe the superficial femoral artery. So that can create trouble. So as I said that if there is any issue, you should take an angiogram and you should not be hasty. And even if you have a failed puncture, it's important that you give a gap for the second puncture. It's all this 2 minutes of waiting after a failed puncture is always rewarding, because what happens that if you get the puncture right on the second time and immediately the reflex is that you give an heparin into the patient, and when the heparin is inside the patient, whatever small puncture or inadvertent puncture may have happened will continue to bleed all through your procedure, and it will create problems later when you are done with the procedure. So it's always good that you have a failed puncture, you think that you have hit an artery, maybe a small branch, your wire not going, you pull out the system, you press there, wait for a few minutes so that the hemostasis is secured there. So this is very important. So as you can see in this case that the puncture though is over the femoral head, but it's high. I mean it's the upper third of the femoral head. So it's not an ideal spot for an example. So what about difficult accesses? I mean day in, day out you will have these problems and these situations where you are not having easy access to the femoral artery. So the causes could be hypotension or a low volume patient, maybe patient been fasting for long, or maybe mitral stenosis is a very common example where or maybe aortic stenosis, the volumes are very low. Sometimes in coarctation of aorta, you hardly feel the pulse femoral artery there, or maybe there could be a peripheral vascular disease, you never know. And sometimes even in irregular pulses. So patient can be serious, in shock. So all in obese people, you may have difficulty feeling the pulse over the drawing. So in all those situations, what can be done? So for that, you have two options. Either you use the fluoroscopic guidance, as I stated, and then I try to explain to you. And other option is that you can use the ultrasound guided. So just to revise you that how does a fluoroscopic guidance help? So as I told you that so for a fluoroscopic guided, you should, I'm just again repeating this thing that you should always remember the relationship of the artery vein with the femoral head. You can really bet on this that the artery is the most central part and it will lie over the central part of the head of the femur. So it will be in the central part of the head of the femur, and its direction is aligned with the so this is the neck of the femoral head, and this neck you should always remember that when you are taking a stent puncture, your needle should be aligned to this inner side of the neck of the femur. And if you go in this direction with the needle and you target the central part of the head of the femur, you will hit the artery in almost most of the cases. So when you are having difficulty feeding for the vein, what you can do is that you have to target the, this is the inner border of the head of the femur, and the vein lies along this. So if you target at this spot, you are most likely going to hit the vein. So this fluoroscopic guidance can help you when you don't have an ultrasound or when there is an emergency, because this fluoroscopic guidance can help you in those situations. And I show you an example here that this was a case where attempted artery and venous access was being done. So what you can note here is that if you see initially, so before I go to this case, let me just ask you that what could be the best thing if you have to puncture both artery and vein? How should you proceed? What should be the sequence of your access? Should you take an artery first or you take a vein first? I mean, there could be debates on that. One may say that taking artery may be a good option, but I prefer to take a vein as the first access, and I recommend that to most of my fellows and colleagues, junior colleagues. The reason is that when you are taking an arterial access and you use the Saldigna technique, you have punctured the artery, you have put in a wire, you just can't keep that vessel with the wire in. You have to put in a sheath so that there is no further bleed, because if you have just put in a wire over the puncture, it will continue to bleed till the time you put in a sheath. So you just can't put a wire in the artery and then go to the vein. So obviously you'll have to put a sheath into the artery before you take the venous puncture. So what can it really create problems with? Putting a sheath may kind of distort the local anatomy, and it can create trouble with taking a venous access. The second problem is that when you are puncturing, you are going blind. So there could be a possibility that your needle may puncture the sheath which is there already placed in the artery. So that can also create trouble. So what I practice and I recommend is that you should first take a venous access, you put in a wire inside. If there is any ooze, it will be very minimal. You then proceed to take the arterial access, and when you have the arterial access, you put in a sheath in the artery, and then you follow it with a sheath in the vein. So this is the sequence that I recommend. So in this case, arterial and venous access was needed. So the first access was being tried was a venous access, and you can note here that this is the sheath inside here. You can see here. So if you note there, the orientation of sheath is very medial, and if I draw it further, the direction of vein, I said, is aligned with the inner border of the head of the femur. So if you see the orientation of the sheath starts along the venous puncture. So what has happened could have happened that the interventionist here has gone with the needle in and may have hit something, may have thought that it's not a good spot, and may have got slightly laterally and hit a artery. So instead of a venous access, initial arterial puncture was done, and very sensibly a sheath was put in, because you should not be dogmatic about when you need an artery and vein. It's not an issue. If you get an artery, you put in a sheath. But they was having trouble getting a venous access, because usually what you do is that when you want to puncture the vein other vessel, you take a half a centimeter of gap or 1 finger gap, and then you go over the stent puncture. So obviously when you have a sheath here and you take a gap, you will be puncturing very immediately, and you are not likely to get a venous access. So what was done in this case, that we used the fluoroscopic guidance, and you can see here that the needle is puncturing just at the inner border of the head of the femur, and you had a access into the femoral vein. So this is how a fluoroscopic guidance can help you, but definitely if you have a USG available and you are proficient in using that, please go ahead and use it, and it will make your life very easy. So this is what you can do when you have a difficulty in access. So till now we have discussed what is the local anatomy for the femoral access, and how should you go about it, and what care you should take and what caution you should take. But despite being very careful, very meticulous, you can have problems in femoral access, and it's no surprise that more and more people are in fact using radial access as the choice of intervention, access for intervention. So the reasons are these complications. The complications of femoral puncture is the most common being hematoma, pseudoaneurysm. We'll discuss all these things. So pseudoaneurysm is a condition when you have a bleeding into the surrounding tissue and it forms a sac, and so you have an aneurysmal sac there. So this is what you call a pseudoaneurysm. Then retroperitoneal bleed. It's a very serious issue. As I said, that if you are puncturing high and you're also additionally puncturing the posterior wall of the artery, there are chances that you can be having this complication. There could be dissection, AV fistula formation. We'll discuss all of these things. Perforation of the artery. Then apart from the bleeding complication, you can have thrombosis of the vessel, acute vessel closure, particularly in people who already have a peripheral vascular disease, elderly people, the chances of having vessel closures. Then arteritis, that is infection. Distal embolization, people with a lot of atherosclerotic burden, when you are putting in and taking out devices, you can easily embolize calcific plaque, atherosclerotic plaque, even thrombus distally into the foot or the lower limb, and it can result into features of distal embolization. And obviously nerve injury, you can damage the nerve through the needle puncture or maybe after compression. And hypotension and vasovagal. Vasovagal is not a very rare complication. It's in fact very commonly seen in clinical practice because of the pain, maybe the hypovolemic status of the patient, because the patient may be fasting for a long time. You can have all these complications. So before going to discussing how to manage complication and what these complications are, I just like to discuss that what are the measures that you can take to prevent these complications. Look, femoral complications are very common, and but on the other side, it's very true that most of these complications can be prevented if we are careful and we go by a protocol. So first, it is important full aseptic care to prevent infection, liberal local anesthesia, pain should be avoided. I have seen patients having vasovagal syncope because of pain. You should be liberal in your local anesthesia at the site of the puncture, but obviously you should be careful that you don't inject these lignocaine into the artery and vein, and you know the complication that can happen. Puncturing the middle third of the head of the femur is very important, because even if you have an inadvertent puncture into or a bad puncture, you can at least press over that area and you will have a good counter pressure. So the chances of good hemostasis is really increased, even if you have a oozy puncture. So this is very important, and also anterior puncturing the anterior wall is very important. So while puncturing, it's important that you are very steady, slow, and try to get this tactile feel. And believe me, with some practice and care, you can really feel the hollowness that happens when you puncture a artery or a vein. You can feel that you have punctured, you have entered the lumen. And it's when you are very careless, you are poking in and out, the chances is that you may be puncturing the anterior wall as well as the posterior wall. So you puncture the anterior wall, you don't realize, you go deep, you puncture the posterior wall, and then you see that, oh, it's a bad punch, you don't have a flush, you could pull back, you again go in. So in this way, you are kind of creating multiple rents in the vessel. So it's very important, be steady, slow, gentle, and try to puncture the anterior wall. And avoid the puncture in the posterior wall of the artery, because it can lead to uncontrolled bleeding. Whenever you are using large size sheath, it's very important that you take a local angiogram, and don't keep the large French size sheath for a long time. It's better that you close it with a per-close device or any vascular closure devices. And when you are taking long sheaths, they are highly prone to have thrombosis inside. So when you have done with the procedure with a long sheath and you are not going to close the puncture immediately, you just replace it or exchange with a smaller size, the same French size but a shorter sheath. And when you have left the sheath inside, don't forget to keep it flushing. And definitely, as I said, that mandatory angiogram when you're inserting large sheaths. And it's one more thing is that before you start a procedure, it's good habit to try to feel the distal pulses, because you have an end point to relate. That suppose somebody has absent dorsalis pedis or posterior tibial artery, so even after the procedure, it will remain like that. But suppose you have a bad puncture and you have to press there, and somebody just comes up and say, I can't find a distal dorsalis pedis artery and posterior tibial artery. So how you are going to relate? Whether it was absent to start with, if it is so, then it's not very alarming. But if it was there before and now it's not there, even though if you are feeling the femoral artery over the groin, there could be that you could have embolized something distally. So it's very important that you have your endpoints noted. Make a habit to feel the distal pulses before you proceed or you prepare the patient for the angiogram. So it's going to give you a lot of safety measures, safety issues in there afterwards. And removing the sheath is also very important. Patent hemostasis should be your practice. I have seen people just sitting over the artery with a lot of gauge pieces to secure a hemostasis. Believe me, definitely I know that if the patient is obese, there could be, you cannot feel the artery, but in most of the people in your practice, if you have removed the sheath, don't forget to give local anesthesia. Before that, the EF permits, give some volume before you start. If the patient is having any vasodilators, stop that during that process, because all these can lead to vasovagal syncope during sheath removal. So when you are removing the sheath, it's important that the pressure over the groin should be correlating with the arterial puncture site, not the stent puncture site. So if you, as in that diagram, if you see here, so if the art, if the so if the stent puncture is here, and if you're but actually the arterial puncture will be at this side. So if you pressing at the stent puncture, the arterial puncture will never be compressed. So it's good that you press your pressure, the maximum pressure should be 1-2 fingers above the stent puncture site. And you should observe the stent puncture site whether it's bleeding or not bleeding during the procedure. And it's very good habit that you press in such a way that you can also feel the arterial pulsation. So if you put in a lot of gauge pieces over the puncture site and just press with your fist or both hands, you are likely to miss all these things, whether you are having a patent hemostasis or not. So whenever you are removing a sheath, it's very important that patient should be given local anesthesia, patient should be having good hydration, vasodilators should be off. The pressure should be 1 or 2 fingers above the stent puncture site, not at the stent puncture site, and you should have a patent hemostasis. And obviously, after the hemostasis is restored, don't forget to check the distal pulses. That it should be, it should match the initial observation. If the pulse was there before, you should have a pulse thereafter. So it's very important that you have an accurate stick for prevention of any complication. You can use a fluoroscopic guided or anatomical guided, as I said, in very patients in which you are having difficulty. The CFA bifurcation is very important. In most of the people, you will have a CFA bifurcation here at the inferior level of the inferior border of the head, but in a lot of people you can have over just center of the head. In that situation, you can't do much. But even if you have a bifurcation here for routine procedures, you can just, even if you are having some bleeding there, you can easily press that side. But you can't press it when the puncture is very low. And you should not go, your puncture should not be above the upper border of the head of the femur, because in that situation, as I said, that the artery usually dips and you will not have enough counter pressure to secure a hemostasis. And you know how to, we have discussed how to change the stent puncture site based on obese people or thin people. So these are the measures that you can use. And obviously I'm going to discuss about the ultrasound guided puncture, which is quite is kind of a very reliable tool for accurate puncture. So these are the measures that you can take to prevent a complication. So coming to ultrasound guided puncture, it can be ultrasound guided with a fluoroscopic guided. So the problem is that if you just rely on a ultrasound guided puncture, so this is my femoral head. So this is our working artery, the common femoral artery. So what can ultrasound do? Ultrasound can help us to see where is the bifurcation happening, whether it's happening at the inferior border. If it is happening very low below the neck of the femur, you are safe. I mean, no way you are going to have hit the bifurcation area. But if it is happening higher, then some problem could be because of procedures that require larger sheets. By ultrasound, you can know that what is the level of bifurcation. By ultrasound, you can see exactly how your needle is going into the vessel and you are having an access. But ultrasound cannot help you to ascertain that you are hitting, you may be you just rely on an ultrasound that okay, you have to hit the artery above the bifurcation. So there could be possibility that if you just rely on the ultrasound probe, you could be hitting a puncture here at the below the inferior border of the head of the femur. So even if you are puncturing the common femoral artery, you may not be puncturing at the most ideal spot. And this can be averted if you combine ultrasound as well as ultrasound with a fluoroscopic guidance. So what fluoroscopic guidance will give you is that the exact skin site where you are going to enter the needle, and you put the probe there and you see further bifurcation and see the local anatomy. You can see whether there is a calcification or atherosclerotic plaque over the artery, and you can thereby modify your puncture depth, puncture height. I mean, at the site where you are entering the common femoral artery. So I'll just discuss a case with you that how do you actually go about it. So how to identify that which is artery and a vein. You know, vein is medial, artery is lateral. So what you see here is that so if you see here, you have an artery and a vein side by side. So maybe the probe is kind of oblique so that it's giving you a visualization of both the artery and the vein. So how to differentiate between an artery and a vein? The thing is that the vein is compressible. It will have a continuous flow, where the artery will be non-compressible and it will have a pulsatile flow. So if I run it here, you see the video here, you can see the pulsatile flow. Now this is compressible. Okay, so this is a vein here. You can see how compressed it looks like. You see here, so it's getting compressed. The upper one is the artery, and that's a and this is the area of your so this is what you call the bifurcation area. So you have SFA. So this this is SFA, this is the profunda femoris, and this is your vein. This is the vein. So this is the point where the common femoral artery is bifurcated into two branches. And if you see further here, if you go slightly above it by the ultrasound probe, here. So I just pause it here. So if you go slightly above it, this gives you the site where you can enter. And obviously you have to confirm this site with fluoroscopy that are you at the level of the inferior border of the head of the femur, so that your puncture happens just at the central part of the head of the femur. So you go above, you have an artery here and a vein here. You can see it very well that below that you are having, and this is almost at that level because you can see that just the profunda femoris is just rising. So this is exactly the level where it's bifurcating. So how do you go about it? What you do is that the longitudinal view section of the view is, you can see here that if you align the probe along the vessel, it gives the longitudinal view, and then you turn it around and gives a trans-sectional view or a cross-sectional view. So this is a cross-sectional view, and the first shot was, so this is a cross-sectional view which gives you a level. The longitudinal view, this was a longitudinal view when your probe is aligned to the direction of the vessel, and it helps to actually guide you for the direction of the needle, how do you proceed. So first what you do is that you take a longitudinal section, you locate the artery and vein, you differentiate it by compression, and then you turn it, you take a cross-sectional view, and you go above the bifurcation, and you are ready for a puncture. So in this case, we did a femoral vein puncture as well as the femoral artery puncture. You can see on the left side of the screen here. So a venous puncture is being attempted here. So you note here that the vein is identified by it getting compressed, and then we turn into a cross-sectional view here. Uh, Here you can see that you have an artery here and a vein here, and this is the needle entering here into the vein, and you can see here this rent here. This is how you can see actually the needle entering the anterior wall of the vessel. So the movement of the vessel probe should be like when you are entering deep, the probe should also be slightly tilting superiorly so that you can follow the needle. So if you just keep it here, it will just, if the needle you are puncturing deep here, the needle is going apically. So you have to also turn the probe this way so that you can follow the direction of the needle. So this is how you go about. Similarly, this is arterial axis being taken. So you can see that it's a pulsatile flow. It's bifurcating here into profundize arising from here, and then we turn into a cross-sectional view. First, we will confirm the bifurcation here, and this is the level, and this is, you can see here a rent here. This is the rent, and you can very well see the needle entering into the artery. So this is how you take a femoral artery access through ultrasound guided thing. And the advantage is that you can have a very accurate puncture, and if you combine it with fluoroscopy, you can really puncture at the site where you want. That is the central part of the head of the femur. A lot of complications can be prevented by this. Coming to a safer, another option for a safer puncture is to use a micro puncture set. So the normal 18 gauge needle that we use for a puncture is a large bore. So inadvertent puncture to adjacent structures can lead to bleeding continuity during the procedure. But if you use a micro puncture in high risk procedures, which I personally prefer in high risk procedures, like for example for TAVI or EVAR, where you should and you must have a good vascular access. In that situation, this comes very handy. This 21 gauge needle is very thin, and it's compatible with 018 wire, and you put in the so you in 018 wire, the normal guide wires that we use for sheets are 035. So it's slightly thicker than the PDCA wire that we are use. So that's a 018 wire compatibility, and you can puncture the vessel, and even if you have punctured inadvertently the adjacent structure or maybe other smaller branches, the likelihood of a bad puncture is less because the trauma will be less, and it can, whatever puncture which has happened inadvertently may seal readily than if you are puncturing with a large bore needle. And also it has a dilator. When you have punctured in, you have put in a wire, you take the dilator, and you the sheet is 5 French, but the dilator is almost 3 French or 4, less than 4 French. So if you take in the dilator here, so you can take a shoot there, and you can see that whether your puncture is at the best site or not. And if you think that it's not at a good site, you just can just remove the thing and press it for 5 minutes, and you're ready for the second access. So that's how a micro puncture can help, and it comes from Cook, and we find it very useful in our practice. Coming to preventing dissections, and what are dissections actually? So dissections can happen because of the wire, because of the hardware that you are taking in and out. So wire dissections can happen, and they are mostly retrograde. So what we mean by retrograde dissection is that that if you see in an artery or a vein, the if this is a vessel here, okay, the flow is from above to below, and when you are puncturing like this, and you create a rent in the vessel. So this is our dissection flap. So the direction of dissection is opposite to the direction of the flow. So your flow is happening in this direction, but your dissection is happening in the other direction. So we call it a retrograde dissection. So wire dissections are mostly because when you are puncturing the artery are retrograde, and it happens because if you are very hasty. Suppose you are puncturing the anterior wall, you just have a flush and you put in a wire, and you can easily create a rent. Or if you are gone deep, you withdraw the needle, you see a flush, you put in a wire, you can dissect the posterior wall of the artery. And how can you prevent it? You can prevent it by two things. First, make sure that you are in the true lumen, and when you are entering, you are pushing the wire in. I mean, you are pushing the wire in. Try to make the angle of the needle slightly horizontal. So when you are, if you are, or maybe in a direction of the lumen. So in that condition, the chances are there you will be in the true lumen away from the wall. And the wire should not be pushed hard. It should be very gentle. If you find any resistance, take away the whole thing and wait and do compression there. So you can prevent retrograde dissections. But the best part is that the retrograde dissections are often self-healing, because if you see that the mouth of the dissection is away from the direction of the flow. So most of the time, the flow will have a tendency to close this mouth of the dissection. So it usually self-heals if you leave it this way. But anterior dissections can happen when you are withdrawing things from the sheath, or maybe the guide you are taking out. The anterior dissections are dissections which happen in the direction of the flow. So if you are withdrawing it, the direction is like in this direction, above and below, as I said, and the dissection happens here. So this is an anterior dissections, and usually these anterior dissections need to be treated because they can result into vascular closure, acute vessel closure, and maybe they need to be treated by a balloon dilatation or even in sometimes a stent. So anterior dissections are serious and they need to be tackled well. But all these complications, all this dissection can be prevented if you are very careful. So coming to troubleshooting here, hematoma, pseudoaneurysm, and retroperitoneal bleed. I told you hematomas are pretty common in femoral access. Most of the hematomas can be treated by compression. Sometimes if the bleeding is very large, or you may need a blood transfusion, and at times vascular intervention in form of internal tamponade, or maybe open intervention, surgical intervention. A pseudoaneurysm is a condition, as I told, that when there is a rent and it leads around into the tissue, and this is what you call the neck of the pseudoaneurysm. So a pseudoaneurysm can really create trouble, and we'll discuss one by one how to tackle it. So first of all, before we proceed, let's discuss about bladder sign. So this image is not a bladder sign. This is a normal fluoroscopy saved of the femoral access. So you can see outline of the bladder here. So what is a bladder sign? If somebody has a severe retroperitoneal bleed, there will be blood collection in the pelvis, and it's a potential space. So what will do is that it will compress the bladder. So instead of this kidney shaped bladder you can see here, the bladder may be compressed to one other side of the or the contralateral side, and you may just see a compressed bladder, and this is what you call a bladder sign. And this is very serious and indicates that there is a severe retroperitoneal bleed. So this is what we call the bladder sign. So coming to hematoma management, I said hematomas can be stabilized with good manual pressure, provided that the puncture is happening over the femoral head. Otherwise, there could be trouble. Large hematomas are difficult to manage by external compression. An internal tamponade can be used. So what is an internal tamponade? Internal tamponade is that you take a contralateral axis, you cross that area with a wire, and you take a balloon inside and dilate it so that you create a tamponade over the site of bleed. And if you keep it for some time and deflate it periodically, it can help to see. So this is the first thing that you can do. Further, a vascular surgery may be needed if the hematoma is not relenting to internal tamponade or is very serious, not amenable to intervention, or sometimes you can use a covered stent. But definitely covered stents have an issue, because if you are putting a covered stent at the level of the femoral head, there are chances that you can occlude the profunda femoris there. And also, since it's a joint area, the stent can get crumbled later and can result into stenosis. But definitely acute management is more important. If there is a future complication, it can be handled easily. So management of pseudoaneurysm, as I said that pseudoaneurysm happens when there is a rent in the artery and it bleeds into the adjacent tissue. So what you can do is that if it is small size, asymptomatic, manual pressure or a probe pressure that is directed at the neck of the pseudoaneurysm, it can really close it and result into thrombosis of the pseudoaneurysm. If it is 2 centimeter or greater in size with a narrow neck, what you can do is that you can use an ultrasound probe to locate the pseudoaneurysm, and you can directly inject a thrombin into it and compress it, and it will result into healing of the pseudoaneurysm. If not, if the neck is wide neck, you will need a surgical intervention here. So let me show you an example here that this case here, if you see here, this patient after the procedure developed hypotension, hemoglobin dropped, a CT was done that confirmed that she is having a retroperitoneal bleed. And so the operator was very emergent on it, and it was taken for a angiogram from the contralateral side. This is the right side. So left femoral artery access was taken and an angio shoot was taken here. So few things I just want to just highlight you here, that what was the trouble here. So if you see here, this is the femoral head, and you can see the leak here and a leak here, maybe from this small branch, and you can also see the vein filling up. So definitely there had been multiple punctures, most likely needle punctures happening. This branch got perforated, and you can very well see that this level of puncture is very high. So after removing the sheath, it became nearly impossible to control the bleeding, because till the time the sheath was inside, there was no issue. But when the sheath was removed, definitely this was causing local hematoma. But when the sheath was removed, there was continued bleeding and the patient developed hypotension. And this patient was taken for internal tamponade. You can see here that a wire has been crossed from the other side and a balloon is inflated. Usually the common femoral and SFA, if you ask me what's the usual size, normally ranges from 5 millimeter to 7 millimeter or so. So a 6 millimeter balloon or even a 5 millimeter balloon will be sufficient enough to create an internal tamponade. And the trick is that it should be a low pressure dilatation so that it creates a local sluggishness in the flow. And you should not forget to this inflation should be not for more than 10 or 10-15 minutes, because prolonged inflation can result into local thrombosis, so it may further complicate the situation. You can use heparinized saline for all through the procedure so that you don't have the catheter thrombosis or the thrombosis on the other side where the sheath has been taken in. So if you see here, internal tamponade was done in this patient and it resulted into closure. So you see that branch which was bleeding here. So the branch which was bleeding has closed and you have a C. So internal tamponade is a good option. Had this not been treated by internal tamponade, what options could have been? That either you take for a surgical or maybe put a covered stent. So this was the vessel here. You can really manage this such complication via internal tamponade. Dissection, as I said, that most dissections are retrograde. They are in opposite to the flow. They are in a direction opposite to the flow of the vessel flow. So obviously, the retrograde flow, they simply by removing the wire or equipment allows to heal them. Anterior dissections are an issue because withdrawal, it can happen because of withdrawal of shape structure, particularly never ever they pull out EBU guide without a wire. So this is the reason, because you can usually create a rent or like a razor effect on the vessel and it can result into anterior dissection. So this is always against the flow, anterior dissection, because you see the dissection mouth is always away from, is kind of in phase with the direction of flow. So most of the time it will keep it open. The dissection flow flap will be kept open and can result into problems. So you can use a balloon angioplasty or a stent placement for the treatment. So coming to AV fistula. So why do AV fistula? What is AV fistula? AV fistula is a communication between the artery and the vein. And it's not a surprise that femoral site or the groin site is a very common site for iatrogenic AV fistulas, because you have artery and a vein both side by side placed. So why it happens? Most of the time it happens if somebody has multiple attempted punctures, and it can create rents in the artery and the vein both, and which can later communicate and create a fistula. Another thing is that faulty puncture. So a lot of tendencies are there that people, suppose somebody is trying to have a arterial access and he goes in with a needle and he finds that he has hit a vein. So the reflex is that most of the time what people do is that they pull the needle and they know that the artery is slightly lateral to the vein. They just pull the needle and then push further laterally. So this situation can create that maybe when it has been pulled, the needle was still in the vein, and when you push in the laterally, what is being done is that the vein is being punctured and now you have an entry into the artery. So though the procedure is done, thereafter you can have communication between the artery and the vein. Or it can be other way, that somebody is trying to have a arterial abscess, venous abscess, hits the artery, pulls it back and goes medially. So this is what happens. And in this case, you can see here that I just pause it here. So you can, so this was a case where a BMV was done. So So this was a case where a BMV was done, and after the procedure was done, BMV, you know, is a very challenging procedure. The procedure was done very meticulously and without any complications. And this was a 6 months, 5 months old 5 months pregnant female lady. You can see the protective lead shield over the abdomen to protect the baby inside. So after the puncture, what was noted after the procedure and the removal of the uh, dynamo balloon, what was noted was there was a spurting of blood from the venous side. So it was quite obvious this was not a venous flow. It was definitely an arterial and it was coming from the venous side. So what you can see is that you can see my hand compressing at that area and we took a shoot from the arterial axis. And what you can see is that you have an artery and a vein, and the artery, the dye injected in the artery is filling up the vein, and this is the area of communication. What can be done in such situations? This case we managed by just manual compression. We reversed the heparin by protamine, and thankfully it healed. But most of the AV fistulas that are diagnosed later, not associated with local hematomas, can be left like that unless it produces symptoms of heart failure because of left to right shunt. If it does, you can either do a surgical closure or maybe a covered stent deployed in the arterial side. So this is how you manage a AV fistula. Now a case of acute closure. So this can also happen that after a satisfying procedure, a high-risk procedure, this was a case of TAVI. It was noted that there was no flow and patient was again taken for an angiogram, and you can see that this vessel is occluded at the level of so you can see that it is occluded there, and in this patient perclose was also done, obviously, because TAVI sheets are 14 French or 18 French, so it's really large, and we usually use a perclose device for that. So this was a case where perclose was done, and later it was found that there was no pulse in distally, and we took the patient for an angiogram, and this was what we saw, that the sternal iliac artery communication and the CFA, the junction at very junction is occluded. So what should be done? You can immediately, what you can do is that you open up the vessel. So this is what we did in this patient. You can take any slippery wire, and in this case a thermo was taken, and you can see it crossing. So we were able to cross the vessel successfully, and as you can see as the wire is passing, you can see that the retained dye is also flushing the distal vessels. So what we did is that we did a balloon dilatation with a 5 millimeter balloon here, prolonged dilatations, multiple 2-3 minute dilatations, and after that we had this flow. So definitely there was no local lesion, just thrombus there, and distal flush was good. We thought about putting a stent, but it's a high flow system. You put the patient on heparin. Had the flow not been this, we could have thought of doing a stenting, but since the flow was good, we left the patient on heparin, and this patient did well. So if you have a vessel closure, it's important that you diagnose in time, and here comes the role of checking the distal pulses before and after the procedures. So if you check the pulses before, there was a pulse, after the procedure you find that there is no pulse, that becomes important. And it also is important in patients with who have an intra-aortic balloon pump left for some time, and there are high chances of limb ischemia if you are not vigilant about the distal pulses. So whenever there is a situation, you should take out the IBP and take an angiogram, see what is there lying, if there is any anterior dissection that is causing trouble or a thrombus. All these can result into acute vessel closure. In this case, this was a thrombus, but some cases you can have an anterior dissection or maybe a pre-existing disease which got aggravated by the procedure, and you had a vessel closure. So this is what you should do for managing acute vessel closure of the femoral artery. Likewise, distal embolization is very common. Most of them are not detected, but sometimes the thrombus may or the atherosclerotic plaque can go distally and can result into what most of the time they are benign, but sometimes they can manifest as livedo reticularis when you have motile appearance of the foot. So most of the time you can just put on heparin, or if you find that there is a significant vessel involved, anterior tibial or posterior tibial, you can put in a wire and dilate it and treat it if you think that it's a major vessel involvement. Otherwise, if it's small vessel, you can just leave it like that and it will self-heal itself. Hypotension post-cath is not very uncommon. In fact, I'll say it's pretty common. Every day in and out in a high volume center, you can have patients having hypotension, particularly post-procedure when the sheath is being removed. So most of the time it is vasovagal. I talked about it. Painless, volumes, avoid vasodilators during the sheath removal. And if you have a vasovagal, give IV fluids, atropine. So if it is not responding to it, there could be some serious problem, and it can be retroperitoneal bleed, and you should consider it to be a retroperitoneal bleed until unless proven otherwise. So you can put the patient on fluids, blood transfusion, vasopressors, tenderloin bird, and immediately before you think of taking the patient to CT or whatever, it's good that you take the patient to the cath lab and check, because what it will do is that it will save precious time for intervention. So as I discussed that if you have a bleed, the best thing to do is to do an internal tamponade, and that will cease the bleed. Then you can stabilize the patient and think of other options, whether the patient further needs a surgical intervention or you need to have put a cover stand. So it's very important that before, if you suspect a retroperitoneal bleed, just send the patient, take back to the cath lab instead of rushing the patient to a CT scan.